Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Oh, yeah, this is in Washingtonian magazine this month. This came out, which talks about many of the things that you already know about MOTAP and the work we've been doing in an effort to increase donation rates. And talks about my past history and how I made it from the early days, went to Africa and came back and started the transplant program at Howard University and just started MOTAP and how it was a successful program that has helped increase donation rates of minorities, of all minorities, and also African Americans. So they interviewed me on this about a month or so ago, and I had no idea this is what they were going to write, but most of it is pretty accurate. Yeah. So, but I think you know most of this already, so it's probably not new to any of you. But anyway, it just came out in the Washingtonian magazine in April. So just wanted to share it. So in your leisure time, you can review it. If you have any questions about it or comments, I'd be glad to go into detail.
Yeah, I was really happy to see that interview that they had with you. Um, talking about your past, especially your illness and hospitalization when you were a child. That was fantastic recovery. And we're all blessed as a result of that.
Yeah, it's amazing. In those days, they didn't really have treatment for TB, so um, I'm blessed to have made it through. Yeah.
Already.
It's amazing how different it is now. We have treatment for most everything, although TB is still a major cause of death in the world, leading cause of death in the world. Yeah.
You said it's the leading?
Because it's in the top 5 of the leading causes of infectious deaths in the world. Yeah. Yeah. So let's go to the next one. It's always interesting to read these articles that they continue to point out that female physicians have lower mortality rates than men, which is something that continues to stand out. Of course, the reason I'm not sure of, but the fact is that every study that I've read over the last 10 years has shown the same thing, that female physicians have better outcomes than male physicians. Mm-hmm. Any comments? Well, it's not something that has dramatically changed over time, because in the last 10 years, every study that I've ever seen says the same thing.
My primary physician had been a female for probably 40 years, and just last year, it they all had moved on or retired or whatever. And
Yeah.
I have a male primary physician now. I like them better. Absolutely. I mean, I, I don't dislike my male doctor, but I like my female doctor more.
Any other comments? If not,
Dr. Callender said we are better.
no, I didn't say. They say.
They said.
All of the data says that they have better outcomes than males. None of them have indicated why, but this says time after time, study after study shows the same thing.
I think women have a sweeter disposition most of the time than a male when it comes to just personally dealing with someone.
It's interesting because when we first started taking women in, because I remember when I first started, you had very few female surgeons, at least.
Mm.
And initially, the female surgeons were much more aggressive than they are now. Now you have many more feminine uh, surgeons, whereas in the past they had a lot of females who had masculine traits. But over time, that has changed, and they do appear to have a more sensitive
Mhm.
relationship with their patients.
Mhm.
Any other comments? If not,
Dr. Callender,
yes.
I think what happens is sometimes when women are in male dominated professions, the first ones try to emulate men.
Right.
And they tell you, like when I was in the debate club, they told me to lower my voice
Whoa.
and to not let the men intimidate them first. So women use tactics like that. I've always had female doctors. Since I had a male doctor, one time, and I asked him questions, and he said, "Well, don't worry your pretty little head with that. You let me do the doctoring, and you be the patient." So I never saw him again. So I've always had female doctors, and I like their manner. And my doctor that I have now is female, and her nurse practitioner.
You muted yourself, Mary Ellen, at the end.
We didn't hear your last comments. But
Oh, I said I've never had a doctor, but my doctor, nurse practitioner that I work now, she said that we are a team. And I've never had a doctor say that, or to a lot of times I have to assert myself to get my message across, or that I'm just not a docile patient, that I'm a participant in my health care. So a lot of times when women are assertive, that's a negative thing in men's eyes.
that's true. Although it's not, of course, the practice of medicine has evolved so that the most of the current physicians recognize that the leader of the healthcare team is the patient, and so everything focuses around them. But prior to the last 20 years, uh, that physician-dominated position was one of the biggest problems in the practice of medicine. So fortunately, as you mentioned, that's changed. Okay, let's go to the next one. Yeah, this is another urine test that looks at DNA that is likely to be associated with cancer as a way of detecting high-grade prostate cancer that may reduce the unnecessary biopsies. But if the test is positive, it means that you need to do other studies. Although and this is predominantly used in those patients who have high PSAs, and those patients generally will need biopsies anyway. But this is a step that, if it comes out positive, it would be helpful in diagnosing. Although still, there are more other different tests that need to be done to identify the type of cancer, whether it's aggressive or passive, and the stage. So it doesn't eliminate biopsies, but it may reduce the number of biopsies that are necessary.
Dr. Callender, what do they mean by high grade prostate cancer?
High grade means it's very aggressive and it's likely to spread rapidly, whereas non-invasive means that it's not likely to spread. And so when you have an aggressive prostatic cancer, then the concern is that it will spread distant. If it spread distantly, then it's not really curable. It's treatable, but it's not curable. So, and the biopsy may determine whether or not it is a high grade or a low grade. If it's a low grade, then that means that it's probably not spread beyond the prostate, and therefore it's curable by surgical means. It's curable by surgical. That's curable by radiation as well.
Yeah. Does that mean the only difference is when you find out about it?
Well, the difference is if you find that you have an aggressive cancer, you want to be sure that it is still in the prostate. If it's still in the prostate, then it's curable. If it's gone beyond the prostate, it is treatable, but it's not curable because it's already spread. And that, to me, is the most important part of what you want to know about your prostate cancer, is whether it is still in the prostate or has it spread outside of the prostate. And that's why they do special tests, x-rays, PET scans, to identify if there are any cancer foci outside of the prostate. Any other questions about it? So this is something that has not yet been tested effectively in patients, but it's something that is coming down the road, which may decrease the necessity for some biopsies. Right now, the PSA, if it's greater than 5, then they are more concerned about it, the prostate tumor getting beyond the prostate. Any comments or other questions about this? As prostate cancer in men is increasing rather than decreasing, and we know that prostate hypertrophy, benign prostatic hypertrophy, and/or prostate cancer is something that all men will look forward to if they live long enough.
Hypertrophy, doc, is the swelling or the growing?
Yes, yeah, the enlargement of the prostate without cancer.
So I'm still a little confused. High grade and low grade. It's only one kind of cancer, but
No, that's not true. There's many kinds of cancer, but cancer may be aggressive, which means it's it's growing very fast, and it's going to spread outside of the prostate. And as long as it's contained within the prostate, then it is curable. But if it gets outside of the prostate, then while it is treatable, it's already spread so that it's not curable. So if you've got an aggressive prostate tumor, then the need for rapid treatment becomes very urgent. Whereas if it's a slow-growing cancer, then it is still curable by radiation or surgery, but it was going beyond the cancer. And that's what the biopsies determine for the most part, whether the tumor is slow growing or rapidly growing. And then the PET scan determines whether the prostate cancer is outside of the prostate.
Okay, thank you.
Any other comments or questions? Because this is one of the biggest causes of cancer in males over the age of 50. Okay, and usually the first symptoms of it are having to get up at night to urinate more than once a night is a sign that your prostate is enlarging and is causing obstruction. And so the two tests that, and you see it, we have another study that's coming forward that talks about the role of the rectal examination and the PSA and the scans of the prostate. So we'll talk about that more. We'll get to those articles. This is an interesting article because everybody has an opinion, and this is the interesting one. But the purpose of getting a whole body MRI is to find out if you got a small tumor or cancer anywhere in the body. And the feeling is that if you catch it early, you will be able to cure it early. But one of the other concerns is that you may get something that's so small it's negligible, doesn't require any treatment at all. And if you have an abnormal finding, you may be frightened and you may unnecessarily get something done. But in general, most people who get MRI scans want to know if they have any kind of tumor. And if it's early, they want to get it when it's curable. Because when cancer is localized, it is curable. When it is spread beyond the original site, it's treatable, but it's not curable. And what does it mean when you say treatable? It means that we can give you chemotherapy to try to knock out the cells, but as long as the cancer is still there, we're just symptomatically treating something. But so when we say it's treatable, we can deal with the spread, but it's whether or not an MRI is something that you should do when you're asymptomatic, and it's 50-50. Some people say it's a good idea because you catch an early cancer that you wouldn't have had any idea about before. And so, and that's the benefit why you have cancer screening to pick up cancers early. And so one does not replace the other, but screening is an important part of the process. So an MRI plays a role, but it's not the only role in early diagnosis of cancers. And this points out the importance of cancer screening. You can see on one hand in the chart, the people who have deaths averted by screening. And so what they're wanting you to do is to be sure you get screened and not replace the MRI with the screen. Any comments or questions about this?
Dr. Callender, when you go to your primary physician, if you aren't having any difficulty or telling them about any pain or anything, they aren't recommending that you have a cancer screening or screening. So what would you do?
Well, if you're having symptoms, then we're not talking about screening, because if you have symptoms, then you have to make a diagnosis of what's causing it, and then treat it appropriately, because it may be a tumor, it may be something else, maybe another cause. So that screening is for people who don't have any symptoms at all.
So I'm saying, but will your doctor just say you need to get screened for cancer just on, that's a normal test that they recommend?
Well, I think all doctors recommend, but most doctors that I know of recommend getting screening. And so if your doctor would recommend that you get screened. For example, if you're over 50, you get in the mail, you'd want to get the screening that is appropriate for men with the prostate and with the female, the things that are commonly screened for with the mammogram and the pap smear and those kind of things. Whereas,
okay.
yeah.
Okay.
So if you go to the doctor and you've not been screened, your doctor would recommend screening.
Okay.
On the other hand, if you have symptoms, then they would recommend specific tests to make the diagnosis of why you're having the symptoms.
Okay. I guess I was thinking MRI, but yeah, she does recommend the mammogram yearly, but I don't know. I thought MRI was what you were talking about as far as getting screened.
Well, no, MRI. Some people use it as part of their physical after they reach the age of 50. They get an MRI just so they don't have to go through screening.
Okay.
And this article is saying that should not replace screening.
Okay, I got it.
It has a role to play, but it plays this major role in the diagnosis of people who have symptoms and other problems. But the screening is a simpler way of doing it and less expensive, and is likely to pick it up early as well. So it's really a matter of people who can afford it will get a whole body MRI and probably not do the screening when in point of fact they need to do the screening.
Okay,
as well.
I got it, man.
So that found a part of the issue is the expense of it.
Yeah, part of the issue is the expense of the MRI, which is much more expensive than the screening.
You have an idea how much it costs?
No, I don't know how much the MRI costs. I know it's hundreds of dollars, but I don't know exactly how much. Maybe you can look it up. But I don't know what it costs.
Alrighty.
Okay. Any other comments about the screening? Right. Now this is an article we've talked about for the last year, I guess. Ms. Brooks, you had a comment? No. Okay. Microplastics are we've talked about the way in which we've been bombarded in our water and everything else by toxic products that are in our water and almost everything we drink, and that how this is one of the causes of cancer. And there's a lot of diligence that's involved in trying to screen out these microplastics that are dangerous to the body. And this is something that has made it clear that it's a very common cause of cardiovascular disease, for obesity, and cancers. And so there are a number of articles recently talking about how we're going to decrease the microplastics that are invaded all aspects of our of things we put in our mouth, water and everything else. And this is one of the articles that we have in the subject today. And while people are still postulating on whether this is the main cause of arteriosclerosis or the main cause of many inflammatory bowel diseases or cancer itself, one of the things that is studied is how do we filter out these products that are these undesirable products. And so now that we're aware of it, the question is, what do we do to screen out the microplastics? And the subsequent article talks about the cost of it and what steps can be taken to filter out these toxic products. Because we've identified it's in the plastics, it's in the water, it's in virtually everything. Any comments about this frightening prospect? Let's go to the next one.
They also found some microplastics leaching from skillets, from the protective coating on the pots and pans.
Yeah, okay. Yeah. Next one, please. This is interesting way in which treatment for mental health. John Robinson used to talk about the fact that psychiatrists can use medication or they can use psychotherapy. He felt that psychotherapy was the best treatment because it involved more human interaction than medication, and touching and feeling and interaction between the doctor and the patient was more likely to result in a long-term healing. And this is an article that kind of proves his point in that touching and feeling patients as well as giving them medication is the best way to take care of mental health problems. It's also the best way to take care of health problems. And this is an article that specifically talks about the impact of touching and feeling on dealing with mental health issues, and suggesting that the more effective way of addressing mental health issue involves interaction with the healthcare provider, along with touching and feeling of the patient. That's what this article is all about. And the data suggests that the therapist that involves himself with touching and feeling and interacting may have the longest long-term effects, longer term effects than the medication, which has other side effects. And often people stop the medication. And when they stop the medication, the positive consequences are lost.
You know, Dr. Callender, there's a best-selling book that also has that in it. And it starts in its first chapter. I will make man, and man needs to have somebody with him. So I'll make woman, and so that they will not be alone. And so from that best-selling book, written millennia ago, we should learn something.
Yeah, and I think we learn it, but we tend to unlearn it as well. And so we decide to take easier methods, and those easier methods do not last as long as the others. So, and the best-selling book is the Bible.
That's it.
Mm-hmm. Yeah.
But along those same lines, though, when they start all the stuff about people touching inappropriately, and they get into, they carry it too far, I think, but they they don't want people to touch people and do this and that. So
That's an aspect of it that has to be considered.
yeah.
That you're right, people can take it too far because inappropriate touching is not recommended.
Yeah, but some people may think a hug or a pat on the back, or
Right,
is
right.
inappropriate, which it isn't. It shouldn't
No,
be.
right.
Yeah, but they just take it out of context and just
Yeah, you're right.
go crazy.
That's one of the problems. Yeah, yeah.
Mhm.
Dr.
Not-
Callender,
yes.
when I talk to a doctor and we're like say right in front beside each other, I reach out and touch his hand. If he flinch, then that's the last time I see him.
Well, that's the Brooks test.
Yes, that's the Brooks test.
Okay.
I also found that as a teacher, I taught for 35 years, touch is important, but on the other hand, it could also be dangerous in certain circumstances.
Yeah, it's very dangerous. Nowadays, with harassment being what it is, it has its risks. Yeah.
But
And it's unusual if you have a harassment case that you win it. So you're right. It has its hazards, but it certainly is healing often. So
I was surprised that they said even a robotic touch is therapeutic as well. They have these little doggies and puppies and teddy bears that move, and that even that touch is helpful. It's therapeutic.
Look at all these women with the teddy bears, and all the children that grew up with teddy bears. All of that's about touch too. So, any more comment about this subject?
And we all know what happened during COVID when we were all isolated.
No touch.
And what they said was so devastating to everybody.
Absolutely. Yeah, absolutely. Yeah. Good point. Touche. Okay, let's go to the next one if there's no further comment. Oh, this is a topic that I won't go into too much detail on, but gene, genetic editing is now with us. And it's important for us to be aware of it, that many of the diseases that we're dealing with can be treated by gene editing. Sickle cell disease, thalassemia, and other ways. And of course, transplantation has been impacted upon this in a very major way. And this is the beginning of a new era because of the role that Jennifer Doudna, who was the Nobel Prize winner for the CRISPR-Cas9 genetic editing that has occurred as a consequence. And so we just need to be aware of the fact that we're just in the initial stages of ways in which gene editing will play a role in our future. And so the real concern that even Doudna had is that it will be abused, and that's why they have actually the NASEM, the National Association of Science, Engineering, and Medicine, has come out with guidelines on which gene editing should be done, and it's recommended to be done for diseases for which there's no other treatment, or in which the treatment can be improved, rather than to use it for designing purposes. And so I thought it was good for us to include this article so that you could read it at your leisure and have a good idea about what our future is going to be with gene editing. One of the things that is not appreciated, though, about gene editing is that we don't really know and understand the full impact of gene editing yet, because one of the good examples of it is the fact that the APOL1 gene that is known to be associated with glomerulonephritis, FSGS, is a consequence of a gene that prevents sleeping sickness. And so what we see as the downstream effect is that it is also associated with kidney disease. Well, when we do this gene editing, we see the early impact, but we don't know what the downstream effect of it is. So that time will tell the downstream consequences of what our gene editing that we're doing today. But we do know that it has been demonstrated to virtually cure sickle cell disease and thalassemia, and also allow for xenotransplantation. Any comments? Just introductory article, so you would have a good idea that gene editing is probably here to stay, and we need to know the ways in which it can help us.
Dr. Callender, I'm very much afraid of the negative possibilities. Okay, because just like with the boys in Brazil and Dolly, that clone, the first clone sheep, there are some forces on the planet that are not positive like we are, and they have evil in mind.
Well,
So,
I think your concern is justified.
But
Very much.
speaking of the transplant, they did another liver transplant from a pig. I guess the male person had theirs several, I guess, a month or so ago, and they just did a woman maybe about a week or so ago, and she seems to be doing well as well.
Yeah. So the impact, the positive impact, is good. What's going to be the downstream effects we have yet to see.
Mhm.
And I think also the fact that we have this political obstacle of fighting diversity, equity, and inclusion without having a comprehensive or a diverse workforce moving forward with these scientific breakthroughs. We have the dominance of white old men and all of their presuppositions and biases. So it is critical that we make sure that the scientists reflect the population.
Well, and I think what is also important is that not that they reflect it, but that the community is involved in all of these technological advances, because that is important that they keep them honest. Otherwise, they will result in a widening of the majority-minority disparity rather than a narrowing. So the role that the community plays cannot be overemphasized in any of these actions, because otherwise the rich will get richer and the poor will get poorer.
I have a question, Dr. Callender. Is there an international, like I'm thinking watchdog group, but probably more appropriately, cooperation internationally for gene editing?
Theoretically, yes, because as a matter of fact, one of the scientists was put in jail because he used gene editing inappropriately. So theoretically, but I mean, the forces of evil are great and are everywhere. So, so we do have international, but I don't know how effective it's going to be about the forces of evil wherever they are.
Is there an international organization, or where does
Yes,
that come from? Is that the NIH or?
it's the NASEM is they had a scientific advisory committee that identified what were the limits of gene editing.
You know what? I appreciate you offering. I don't think they can hear me. You know, in the mornings, I'm gonna get out of this. I'm gonna get it. I'm getting it.
JCS iPhone?
I can't get out of it.
You had a
I
comment?
do the Zoom
Probably
thing on Thursday mornings, and at 9. So I was listening in on that, and I appreciate you offering that. So what I did last night, I just kept brushing it and put a curler here and there.
Darryl,
And
you want to mute them? There you go.
That sounds like
Understood.
Janice.
Yeah.
She was on a phone call.
Mhm.
Oh, okay. All right. Any other comments about this gene editing? Because I think the comments are right on target here. Any other comments or thoughts? Okay. Darryl, you're quiet on it. Any comments from you?
No, I'm fine. I'm just being very attentive and trying to admit people in since John made me host.
Oh, I see. I noticed John wasn't here today, so.
He just joined. I don't know if he's still on, but he's attending a music convention. He and Carol at our music convention in Atlanta.
Oh, the annual.
Yeah, there
Yeah.
he is.
Oh,
Yeah, he's waving. He's got us on mute.
yeah.
He's at a board meeting.
Okay. All right.
Double dipping.
Any other comments about that article? Anyway, this is an advanced protocol for improving prostate cancer detection because prostate cancer is growing and increasing. PSA testing remains an important part of it, especially for people of color. And they are now identifying additional tests that they want to include so that they did a screening to include a 4 callicrine panel to identify high-grade prostate cancer with the DNA testing that we talked about. And then they also did tests with targeted biopsies. And they found that those people who had the entire screening tended to do better. And so this led to them to want to have a screening that involves more than just the PSA and the targeted biopsies. And so down the road, you're going to see some recommendations that involve an additional screening tests for prostate cancer. The reason is because the results of the tests that they did were very small and were not statistically significant. And so this is not the answer yet. It's a step in the process, but it's still something that is being studied. One thing to me is clear is that if you're above the age of 50 and you're a male, that you need to at least have a PSA and either a rectal exam or prostate MRI to evaluate the prostate. The anorectal digital seems to have lost favor, but it's still a test that is good at detecting prostatic masses, lumps, bumps, and hardening of the prostate gland. But of course, now with MRI screening of the prostate, for many, that is a replacement, although it's an expensive replacement. Any other comments about it? We're talking a lot about colon cancer and the colonoscopy. Colorectal cancer is a very common cause, and so is prostate cancer. So both of them require our attention. The only difference is that colorectal cancer is found in men and women, whereas prostate cancer is only found in men. Any comments about this? I think this is a work in progress. Next slide, please. Now, this is some would argue long overdue, but the United States partnered with 50 countries to prevent future pandemics. I don't think they're going to be able to prevent future pandemics, which we have about every 100 years, but it will at least help us to be in a better position to handle the global pandemics, which I think will still occur. But at least we won't have such a paucity of countries that are able to deal with it. So many countries couldn't afford the vaccines, and I hope that this will put things into place so that more countries will be able to participate in the vaccination processes that occur. But I think this is a good start. One of the problems the last time was that Trump denied the Obama processes that were put in place. He pretended they didn't exist. They were there, but he just refused to use them. So this is hopeful that that we will work with other countries so that we don't have to wait until a pandemic occurs to have a process that involves the developing countries and the developed countries. And the emphasis here is on the Asian countries and the African countries that have not been included in the past. Any comments about this article?
I'm wondering whether China and Russia and North Korea is part of those in 50 countries.
Well, to me, those countries are developed countries, although Russia is considered a developing country now, but China is, of course, a developed country. So,
yeah, but I mean, that's where the pandemic came from, allegedly. So.
Yeah, but even if it came from there, the idea is to have things in place so that wherever it comes from, it can be addressed. Now, I have no idea whether China or Russia or the eastern part is part of the 50 countries because they didn't identify who they are. And 194 members, but only 50 signed up. So it suggests that your concern is a valid one and that many of the Eastern countries may not participate. But as far as I'm concerned, if they actually have the African countries and the Asian countries, I think that's a good start anyway. Okay, let's go to the next one. Colorectal screening and primary care. They have another blood test that will help identify the DNA aspects of it, which and they have a cost here of $895. And if it's positive, you're still going to need a colonoscopy. But anyway, it's an additional test that may help you make a diagnosis of suspicion of colorectal cancer, which would then warrant a colonoscopy. This is for people who decline screening colonoscopy because the colonoscopy is still the gold standard. The only change is that it's recommended that we go down to 45 rather than 50. Next article, please. Here's an article that talks about us recognizing that we don't get enough sleep at night and that we worry about it, but we don't do much else. The recommendation is actually 7 to 9 hours a night. And many of us do not get the recommended 7 to 9. And why? I don't know why, but I know that many students and many professionals early in their careers sacrifice and get about 5 hours of sleep a night and think that's the norm because your bodies can stand it when you're very young. As you get older, the brain needs more time to recover. And but the expectation is still 7 to 9 hours. How many of you get 7 to 9 hours? Not very many, huh?
On vacation only.
Amen.
That's not good enough. Yeah.
Dr. Callender, do you think that a person, okay, I'm talking about myself now, who worked at night for 30 years, and I got accustomed to a routine of sleep. I would come home and sleep maybe from 8 to noon, 9, 10, 11, 12, 4 hours. Then I would get up and do whatever I had to do, if I had an appointment or go to the store or whatever. And I wouldn't go back to sleep maybe until about 7. And I'd sleep maybe 3 more hours before. And my body got accustomed to that, so much so that even when I started working in the daytime, it was hard for me to get up in the morning, and I stayed up late at night. So, does it really matter if you have trained your body, I guess is the best word, to sleep less, and you've done it for so long?
I don't know the answer to that question. I know that there are many people who exist on 5 hours a night for so long that they don't change. I know my boss, LaSalle Fall, I think he slept 5 hours a night all of his life. And there are many people who do that, but that doesn't change the fact that the body needs 7 to 9 hours of sleep a night. And yes, people do get adjusted to that. And but that doesn't change the fact that the requirement is 7 to 9 hours a night.
I saw that John Tatum just put in the chat, does certain medicines cause sleepless nights?
Yeah, the insomnia is a side effect of some medications. And so if you have that as a side effect, then you need to change the medication.
Dr. Callender, when I was teaching and working, playing music during the week. So I would come home from school and sleep from like 5 to 10 maybe. So that was 5 hours of sleep. And then I would go to do a job, get there 11 to 2, get home at 3 and sleep from 3 to 6:30, something like that. So the question is, and it's sort of like what Betty was saying, breaking up the hours. If it adds up to 7 or 8, is that okay?
Yeah, I believe so. I guess is that the point you're trying to make? Yeah, I think that your body needs about 8 hours of sleep, and if you don't get it, you kind of pay for it. But I think what you and Betty have done is you've accommodated so that you have the 8 hours of sleep, but it's broken up into different parts. And so far, there's been no study that has identified that is counterproductive, because the recommendation is 7 to 9 hours of sleep in 24-hour period, and they haven't done enough study that differentiates between those people who break it up and those people who do it solidly.
Yeah. Exercising can certainly help sleep, particularly a lot of walking and weightlifting. There's some things that we do that affect affect our sleep quality, like watching TV screens or computer screens. That the light that you're taking into your eyes, it kind of breaks up your circadian rhythm, uh, because like naturally, uh, before we had TV and whatnot, and surrounded by light, it got dark. You experienced a couple of hours in darkened conditions, and so you got conditioned to go to sleep. Now we spend our life in a lot of disruptive light, in particular television programming. The screen changes on the average every 3 seconds, and it makes you nervous. And it really that nervousness can persist for a couple of hours. You watch TV and then you go to bed and you wonder why you can't get to sleep right away. And it takes about at least an hour to calm down from all that jerking around that your eyes have been doing with changing TV screens.
Any other comments? If not, Let's go to the next one. This is something that is brought up because many people who have dementia are treated with antipsychotics to keep them under control. And this article indicates that these antipsychotics have an increased risk for stroke, heart attack, heart failure, and kidney disease. And so it's standard practice for the nursing homes to use these antipsychotics. And so when you have your loved ones who have dementia and they go to these places, this is one of the things that may be harming them more than anything else. So this is an article that points out that it's not all that safe for them to be getting those antipsychotics to be controlled. How else are you going to control them? I don't know. All I know is that this is an additional cause for concern for your loved ones who are in nursing homes, in which the standard practice is to put them on antipsychotics.
I guess this relates to that other article about touch and feel and talk, and we need each other.
Yeah, and that antipsychotics will not replace it. That's kind of what it's saying, yeah. And if you replace with antipsychotics, you pay a price. Now the question is, what are the nursing homes going to do about it? And that's this is relatively new information. It's been interesting to see how they address this information.
So, Dr. Callender, those medications are like to keep the patients calm, rather.
Yes, yes.
You know, but a lot of memory loss people only have short periods of hyper behavior. Usually in my experience, they're not usually in need of calming down.
Well, a lot, there are different types of dementias. There's some dementias in which they become violent. There's some dementias that become very restless, and so one of the easiest ways to do it is to over medicate them, and that's the easy way to do it. Just give them antipsychotics and knock them out, and this is a cause of concern for us to reevaluate those processes.
Yes, I have a brother who's in a nursing home, and they indeed, I don't know that he was combative at home, I guess, so maybe he was there too, but he definitely is on some type of drug.
Medicated. Yeah.
Where he wasn't at home. My own personal opinion, I think it's much better for people to stay in their own environment, if at all possible, rather than to go to a nursing home.
I think there's much evidence to agree with you.
John has put something else in the chat, so.
What does it say? You want to read it for us?
I'm trying to see now. These the same as psycho.
Yeah.
Yes, drugs. Yeah.
Yeah.
Okay.
Oh, yeah. Yeah.
Psychotropic.
Tropic. Okay. Yeah. Drugs.
And I think something that you have done by this support group, it's important for the community. Mm-hmm. Because yes, usually, or in my experience, individual family members as caretakers can't do it. by themselves. They need support. But with the education of the community, I think there are opportunities for the community to support the family taking care of someone with dementia. And I think we've allowed society to put a value on people with dementia in our families. And I think it's important for community to reassess some of that.
Well, I think one of the things is that they have so many available groups to help the family. Now, I'm not talking about the compatible person who really needs to have medication to keep them under control, because you may have some compatible patients who may hurt the family members. But with that exception, there are, as you say, there are many ways in which the supportive family, along with the community, can help take care of those patients at home. If you have enough family members and people who care enough, and that would make a difference, because all things being equal, when they're around familiar surroundings and an environment that they're used to, for the most part, they are better off. Any other comment? Next one. Well, this is something that we talked about before, that they have a speech test that can make the diagnosis. And the one thing that I think is very important, if you find that you've got a relative who got early signs of dementia, is to have the family involved as early as possible, so they can be very supportive, so that the person doesn't get lost, doesn't do things that they shouldn't be doing, and so they cannot be taken advantage of. So that having the family involved as early as possible is important. And so that's a place where this kind of test could be of value. But as a standalone, it's a problem. But if it's used as a way to make an early diagnosis and to support the family members so that they don't hurt themselves. Sometimes you have to take the car keys away. You have to do a number of things that may be important in supporting this family member that has developed dementia. Any other comments or thoughts about that?
Dr. Callender, this harkens back to my childhood. I had speech therapy. I stammered and stuttered. So this kind of reminds me of that. And I think there are people that may have that same pattern as they grow older. Not as many, of course, as in childhood, but I'm just wondering if that could be confused with something else. It's not directly related to dementia.
I think many people are labeled as a consequence inaccurately, and that's the danger of a test like this. If you don't have the proper people monitoring and evaluating it, because there's an interesting article that 10% of children are supposed to have ADHD, and of course that percentage probably is the same as it was when we grew up, but we handled it differently, and a lot of it has to do with whether the family was supportive or not. You teachers have dealt with it more than I have. So, any other comments from many of you out there who are teachers with the ADHD? Did you see much of it in your classes and as you taught?
I didn't see much, but I did see that, and on the other end, autism as well. I even had one child that had uh, God, I can't remember the name of the disorder, but he had outbursts.
Oh, yeah, that one. Yeah, yeah,
And
Rats, maybe.
Tourette's. There you
yeah,
go.
Tourette's, yeah.
I'll never forget that. I was sitting in the classroom. I heard these noises, right? And I couldn't figure out where they were coming from. And this kid had it, and since I'd known about it, and they had a movie out about
Tourette's.
yeah, that the one of the stars of the movie had Tourette's, and so I was aware of it. So at first I thought somebody was playing with me, right? But then once I found out where the noises were coming from, I didn't react like I would have had I not known. And I pulled the child up in the hallway after the class, away from the classroom, and I asked him, and he said, "Yeah, he had Tourette's."
Hmm. Yeah, it's interesting. Any other comments?
Sometimes it's so important for children, in my experience, to understand what's happening, because in their understanding of what's happening, they have more control. And so often we felt that keeping that information away from them and having an environment that supported it was more beneficial. But in my experience, just teaching the child about what's happening has had a far more positive and long, and there's greater longevity in the treatment because of their involvement. And we can see that in everything. I just think sometimes we do not allow children to be part of their development, and we don't explain enough of what that development should be.
Thank you for that contribution. Any other comments? This article is an article that we talk about cannabis and what a great drug it is and all that stuff. And sometimes we don't talk about the consequences of chronic cannabis use. And this is a syndrome that is unique to cannabis that is now being reported for people who are chronic cannabis users. And for sometimes we talk about cannabis as though it is a wonder drug, and in many instances it can be, because it can be used sometimes in transplant, sometimes in eye situations, and in sometimes for certain pains and migraine and other things. But chronic cannabis use has its side effects, and this is one of the consequences of chronic cannabis use. Not as legal in DC and many other places. We're more likely to see some of these chronic cannabis consequences. Do many of your children and grandchildren use cannabis now?
Yeah, so
No
I don't
comment.
know about them, but I'm still skeptical about using it, for medicinal purposes.
Well, and there are few. Most people who use it are not using it for medicinal purposes.
I realize that too.
Yeah.
I realize that.
Yeah.
I think anytime you smoke anything, it's dangerous. Anything.
Yeah.
Yeah, I agree.
Okay, if no, let's go to the next one. No comment. This is a study that looked at who was likely to have a high risk for second breast cancer. And they actually did studies, and they identified that there was a pathological variant that had a significantly higher risk for secondary primary diagnosis. In situ is cancer where the cancer is confined to part of the breast, whereas invasive breast cancer, it has really invaded the rest of the breast tissue. And it is thought that the in situ cancer, once if the surgery is done, one of the things that we do know is that it does occur in the opposite breast, so that a secondary cancer is something that is likely to occur in the obviously in the invasive one. If it's not removed, it certainly will recur. But the in situ also has a risk of bilaterality. But what they concluded that was that if there weren't any pathogenic variants, that the hazard risk was pretty small in comparison to the invasive disease. And this is determined by biopsies and looking at the cancer to see whether it has invaded the breast tissue or not. One of the problems with this study and why it's not generally applicable is the numbers are too small. So generalizing on any of this is not appropriate, but it is important, at least for the breast cancer, to be looked at and analyzed, and also once you have cancer, to continue to look at the other breast because having a second primary is not unusual. So because you've had one cancer does not mean you won't have a second cancer in the opposite breast. Next article, please. So many benefits of exercise. The fact that it helps your brain as well as your heart is good reason for all of us to recognize and take advantage of the physical benefits of exercise. Realizing that it's particularly helpful for people who have severe anxiety and depression, to help with that. But it's almost, you wonder what else does it help, because it seems to help almost everything. Exercise, yet close to 40% of the Americans do not exercise for 150 minutes a week. So it's something that makes it pretty mandatory that you exercise. So many benefits from being active and moving around. So keeping still is the biggest for your thought processes. Sometimes good book says stand still and consider, but for exercise, it's keep moving.
Again, here, I think community is so important because we have to have safe and convenient ways to exercise.
Well, there's so many different ways to exercise, regardless of your disability, so that some people can't exercise because of arthritic limitations and other things, but there's always ways to exercise uh, in different ways, regardless of the disability. One size does not fit all, so that some people can only exercise in water. Some people can. There are different variants, but everyone can exercise. You may not do it the same way you do, or I do it, but there are different exercises that you can do.
Dr. Callender, one exercise that's exploding recently is that pickleball. A lot of people are doing it. A lot of people like it.
Whatever works. A lot of whatever works. Let's go to the next one, please. We've talked about this increase in syphilis, and so that the doctors are advising more screening whenever you get pregnant, so that we're sure that the newborn does not have syphilis, as syphilis cases are increasing. Now, this is a surprising turn that syphilis has now become so common. I know when
Some people were touching.
What'd you say, Dr. Perez?
Some people were touching.
Yeah. 3,700 babies were born with congenital syphilis, 2022. Wow. And it has so many ways of manifesting itself that are not good. Okay, let's go to the next one. Just to alert your children and grandchildren and great-grandchildren. It's an interesting weight loss drug that reduces sleep apnea severity in obese patients. This new drug actually is the first drug that really reduced sleep apnea. It didn't say that it's the gold standard, but it did say in people who are overweight that it can reduce sleep apnea. It's just good to know it hasn't been approved for this yet, but it has shown a 55% reduction in irregular breathing episodes. Right now, CPAP and is the gold standard for treatment of obstructive sleep apnea. It remains so. Although Inspire, of course, is another way of treating for some people. Next article. This is we all know that red meat has its issues, especially the processed red meat. And this is the identified metabolite that they found. that increases the kidney disease risk. I think this is just proving that the less red meat you eat, the better, and that this is the metabolite that's responsible for the kidney injury. And so, and I guess the moral of the story is that red meat does increase kidney disease risk. In many ways in which the processing of meat has become a problem, and it's clearer that the less red meat you eat, the better off you are. But this is just identifying the particular product in the red meat that is causing kidney disease.
Dr. Callender, I think I almost understand it, but can you explain what a metabolite is?
Oh, metabolite is something in the food that is responsible for causing a problem. They identified this particular chemical, and this particular chemical, which is another term for metabolite, is responsible for causing kidney disease. So that when they say the metabolite, that means this particular portion of the meat product, this chemical in the meat product, is what is responsible for causing chronic kidney disease. Does that help you at all or not?
Yeah, it seems like to me, I was thinking that it meant a result of the breakdown of the red meat.
Yeah, that's right. Yeah. In other words, when you digest it, the part of the red meat that is responsible for causing kidney disease is this particular TMAO. That's the particular aspect of the meat that they've identified that causes it. So what you said is pretty much right. Yeah.
All righty.
Next on,
Yeah,
next on.
Well, the way I
comment?
understand it is that your gut bacteria metabolizes the red meat, and the gut bacteria, as a result of metabolizing it, produces metabolites.
Okay. This is people who have hyperlipidemia need medication when the diet is not effective at reducing the cholesterol level. And of course, high cholesterol levels causes arteriosclerosis, which causes all kinds of cardiovascular diseases. And so for those people who cannot be controlled by diet, they have to take medications, and this particular medication reduced the cholesterol by 50%, which is very good in terms of keeping your LDL, which is the cholesterol that causes arteriosclerosis. The most severe type of hyperlipidemia is the familial one, which is harder to reduce by conventional means. And so this particular new drug may be helpful for that particular disease entity. This is interesting that for every 40 milligrams that's reduced, you reduce major cardiovascular risk by 20%. So this would be a very important drug, perhaps. We'll see. Time will tell whether this is something. The thing about this is that this was more of an injection rather than a pill. And so you just take injection once a month, and that might be easier for people to take than uphill. So that's what's attractive about this new medication. Dry eye is a condition that we really never understood what was causing it. And new studies are suggesting that there's a bacteria in the healthy eyes that is responsible for dry eyes. This is a study that suggests this. The whole story is not out yet, but this was done in Australia, and whether this is true here in the United States is not clear at all. But at least this is a study that could be done here to find out if the Streptococcus and the Pedobacter, Acinetobacter species are present here in the United States. And it's food for thought. Dry is a fairly common condition that people have to put drops in their eyes commonly. And so if it is a bacterial infection, then an antibacterial would cure it. But so this is an early research that may or may not turn out to be the cause of dry eye. So we shall see.
Just a comment that dry eye and dry mouth can be symptoms of diabetes.
Yeah, it also can be symptoms of other diseases. So when you have the combination, you're right. You need to look for something. If you get dry eye and dry mouth, then there are other syndromes to worry about. Diabetes will cause it because you become dehydrated with diabetes, and so you then get dehydrated, and that's causing it. And this is an article.
Doc, you got muted.
Removing the microplastics from public water will cost billions of dollars, and they talk about some other ways of filtering out these microplastics from the water. And if you go down the slide, it identifies 3 or 4 ways in which they talk about keep going down to the bottom. Steps to protect your home. And they talk about activated carbon. I don't know how you get the activated carbon. Somebody may know. And then reverse osmosis is a membrane technology. And then ion exchange resin. It's interesting they talk about doing this but this would probably have to do in a treatment facility because we don't have that at home, although it says that, but I think right now, most of the PFAS contamination is something that we really have no way of addressing at home, unless you have this activated carbon. Anybody have any access to anything like that? Because right now, all of us are exposed to these compounds, and if they say that billions of dollars are required, I haven't seen anybody that's allocated the billions of dollars necessary to filter out these products that are affecting our health in many different ways. But anyways, it's good to know that they're working on it. That's all I can tell you about that. Yeah. And this is another single subcutaneous medication that since, we found out that 3 out of 4 patients who are on blood pressure medications are not controlled. And so suggested that this single dose drug subcutaneously might control blood pressure for 3 months at a time. And it worked. So this has not been approved by the FDA yet, but this is something that will maybe help us do better with control of hypertension, because we've not done well so far. Most of the patients that we examine in the clinics, for example, and we do the blood pressure studies, are out of control, and they know they're hypertensive, and they take medications sometimes. And so this is the kind of drug that one dose might work for 3 months. And so this may well be what we may have to revert to, because of the fact that we're not taking medications properly and therefore not controlling hypertension. And remember, the studies indicated that the number of deaths from cardiovascular disease has not changed over the last 10 years. And so this is something that we may have to resort to in the future, to have injectable treatments, since we won't take our medication like we should. Anyway, this is to let you know that there may be help coming down the road, since we can't control ourselves by taking the medication properly. We can get an injection down the road. And it's not available yet, but it may well be something that will help us. This is another way of controlling obesity, in which they put in place something in the intestine called an endobarrier. And this is a reversible procedure that causes you to lose weight and also lower your hemoglobin A1C, because we know that obesity results in diabetes as well. So this is something this is a new thing on block that has not yet been FDA approved, but it showed that it worked. The fact that you'd go in and have somebody put a lining in your intestinal tract, so that you, because to control your obesity and your diabetes is another way of controlling diabetes and obesity. Now, obesity and diabetes are closely linked. They call it endobarrier treatment, and this is all experimental. But just to know that there's so many ways people are trying to address obesity and morbid obesity, which is, this is present in close to 40 to 50% of the American population. Next, and this will be the last article, people with blood type A groups are more likely to have a stroke than other blood groups. Why, it doesn't really explain, but the fact that your blood type A, you're more likely to have a stroke than people of other blood types. Why remains unknown, but this is the first test that has identified that. So maybe other tests will be done that will unravel this mystery for those people who are type A blood tests. Okay, that's the last one we'll do for today. We're well past 10:30. Thank you for attending, and any closing comments that you want to make? If not, thank you. Have a good week.